abundantly pleased. I am so honored to be here, and I'd like to thank our organizers for thinking of me and asking me to speak today. Can you all hear me? Yes? Okay. And I've been asked to speak on two topics. This first topic we are going to cover is examination and evaluation of the pupil. You've heard already a bit about the afferent pupillary defect, so we spend little time on that, and we will spend the bulk of the time on efferent defects or anisocoria. Okay, so the relative afferent pupillary defect, if you remember, represents the difference in light input, the difference in light sensitivity between the two eyes, and you can detect this by the inequality of the pupil light reflex between the two eyes. Now, why is the relative afferent pupillary defect so important? It is a very good, very sensitive indicator of optic nerve damage in that eye. Retinal disease, yes, can cause a relative afferent pupillary defect, but usually the retinal disease is so severe, like a central retinal artery occlusion, you don't need the pupil information to make that diagnosis. Now, I remind you that the relative afferent pupillary defect is not caused, it's not explained by any corneal, lens, or vitreous disorder, okay? And the relative afferent pupillary defect is not caused, is not explained in general by an anisocoria. So now, how do you look for an RAPD? Somebody mentioned this before, the swinging flashlight test or the alternating light test, and I show you here in schema, then we'll look in a video. So you shine the light, of course, in one eye, and here what I show you is the movement of the right pupil in red and the movement of the left pupil in green. So of course, I shine the light in one eye, and both pupils will constrict. Now I move the light to the left eye, and both pupils move, but less well. I come back to the right eye, and you can see both pupils are constricting strongly. You can see how small they are. And then when I swing to the left eye, both pupils, again, less good constriction. So this patient has a left relative afferent pupillary defect. Now let's look at this in the clinical situation. This is a 61-year-old woman. She says there's something wrong with the vision in her left eye, but she's not specific. And we find, well, it's okay. She's 20/20 in both eyes. Her Amsler grid is normal. The fundus is normal, so we're being not so worried. But let's check the pupil. Could you click on the video, please? Now, do we think she has a relative afferent pupillary defect? You can turn off the sound. So for me, it's like, yeah, maybe there's a relative afferent pupillary defect, but the better trick, can you start the next video up here, is to turn off the light. Whenever you check for the relative afferent pupillary defect, if you turn off the light in the room, first the pupil gets bigger, and the retina becomes more sensitive. So of course the pupil is now more vigorous, it's more robust. So now we can see how clearly this pupil reacts to light, good reaction, and we can see this pupil already not so good. And now, when we swing to the other eye, we can very easily see the difference between the two. Okay, so we know there is an optic nerve problem now in the left eye. Even though she's 20/20, we find a big nasal defect, and we are not surprised that she has a compressive lesion, in this case, a meningioma crushing the left optic nerve. So the final tips I leave you for the clinical alternating light test is please remember to turn off the light, darken the room. Do not use a weak light. Use a very focal, bright pen light. Make sure your patient is looking far away, not accommodating, and maintain a regular rhythm. For me, I use a very simple rhythm in my head. I count 1, 2, 3, swing. 1, 2, 3, go back. 1, 2, 3. Okay? And you are going to watch both, both the constriction and the redilation of each pupil. Okay, I think we'll talk about RAPDs later again. So now I want to move to the evaluation of anisocoria. This is when the two pupil sizes are different. And this really is my 4 basic step program that I use in all patients. And we will talk about each in more detail, but very quickly. Step 1, examine the iris. It sounds silly, but very important. Step 2, check the pupil light reflex. If it looks abnormal, check the near reflex. Step 3, measure that anisocoria, both in darkness and in bright lights. And the last step, only if you need it, do we do pharmacologic testing. So sometimes we don't need step 4. So I want to share this case with you. This is a young girl who has a big pupil, and she went to the emergency room, and they said, oh, the pupil has a poor light reflex, and they put in 2% pilocarpine, and the pupil did not react. So they said, yeah, we think she's putting the drops in the eyes. But they forgot the first step. They forgot just to look at the iris. So if you take her to the slit lamp, please look here at these tiny arrows. At the very edge, you can see this irregularity, right, of the pupillary margin. These are areas of torn sphincter. The iris sphincter has been torn. So if you go back and ask her, when did her pupil get big? Well, she played in a basketball game and somebody hit her eye with an elbow. And then after that, her pupil got big. So this is an anisocoria from an iris defect that is specifically a traumatized sphincter. Okay, this is a small pupil. Somebody thought was a Horner's, but when they put the 2.5% phenylephrine, no reaction. So we go back to the iris, and with transillumination, I think you can all see easily there is transillumination defect, iris atrophy, and this is why the pupil doesn't move. The iris dilator muscle is faulty. So just please remember to look at the iris, and whenever you see a pupil that might be pharmacologic, it doesn't react to a direct acting agent like 2% pilo or 2.5% phenyl, just think that maybe it's mechanically restricted because of an iris defect. Okay, now we're going to move away from eye disorders and iris disorders. Now we're going to consider neurologic causes of anisocoria. And now it's very important that you do steps 2 and 3 together. First, you check the pupil light reflex of each eye, and please measure or look at the anisocoria in light and dark. Because right now, you don't know which is the bad pupil, the big one right side or the small one left side. How do you know? Well, this is what I will call for you scenario number 1. Okay, in scenario number 1, when you check the light reflex, oops, the big pupil has the poor light reflex. And in this scenario, when you look at the anisocoria under bright light here, you can see it's very big, but turn off the light, and the anisocoria is almost gone. Okay, this is very easy to see. Oh, and I want to tell you that this is not the natural appearance of the Swiss people. We really don't have eyes so close together. This is just a prismatic trick. Okay? Okay, so in this scenario number 1, large pupil, poor light reflex, anisocoria in bright light, you have really 4 possibilities. Okay? This first possibility we already talked about. You should throw that out with your iris examination. Pharmacologic mydriasis is really at the end of your evaluation. So mostly in this scenario, we're worried about a parasympathetic palsy. Okay? Now, which parasympathetic nerve? It could be here, and this would be a third nerve palsy, or it could be here, And this would be a short ciliary nerve palsy called a tonic pupil. How can we tell the difference between a third nerve palsy and a tonic pupil? It's actually pretty easy, right? Because the general rule is that the third nerve palsy almost never, and I know that's not very good English, but really almost never presents as an isolated pupil palsy. Okay? You can almost always find ptosis and or motility deficits. So when you see a big pupil, look at the eyelid and look at the motility, because here in this big pupil, if you see the ptosis, the eye doesn't move up, it doesn't move down, it doesn't adduct. This is easy. This is a third nerve palsy, complete. It's a little harder when it's partial. So here's a young man with a headache and a big pupil that doesn't react to light. It's worse in light. There's not so much ptosis, okay? And the eye can move up. The eye can adduct somewhat, but we see very clearly the eye doesn't move down. So now we say this is not isolated pupil problem. We have a motility deficit. This is a partial third nerve palsy. Why is this important? Because complete or partial, okay, either one, any acute third nerve palsy that involves the pupil with a big pupil is a neurologic emergency. This patient goes to your neurologic colleague. This patient goes for neuroimaging, because there are several bad things that can be happening in the brain. So this is a very important rule to remember. Okay? Okay. But now, let's say your patient with a big pupil, you checked the eyelid and it's okay. You check the eye movement and it's okay. Now you have an isolated unilateral pupil palsy. Many of you call this unilateral mydriasis. And if it's only the pupil that is the problem, I ask you to consider that maybe this is a tonic pupil. A tonic pupil physiologically represents a postganglionic parasympathetic palsy. So we're talking about injury to the short ciliary nerve or the ciliary ganglion. And what's special for the tonic pupil is later there's going to be aberrant regeneration. So let's look at this. When those short ciliary nerves are damaged or cut, okay, then what happens? Immediately, the sphincter, the iris sphincter, is denervated and the pupil gets big. Immediately, the ciliary muscle is denervated and the reading vision is lost. This is acute. And when you check the light reflex, it's poor. When you check the near reflex, it's poor. And maybe you think, this looks like pharmacologic mydriasis. Maybe she's putting drops in the eyes. But I'm going to tell you, remember to look at the iris. Okay, please start the video. What I want you to look first is at 12 o'clock. Up here, please. We turn the light on, and it's not moving so much. Yes? Let's look here on the side. Not moving so much, but now let's watch the bottom. You see, it's very nicely pinching. This is what we call sectoral sphincter palsy. This sector is paralyzed. This sector is working. You never see this in pharmacologic mydriasis. You never see this in third nerve palsy. So if you can learn to find it, it's so helpful to you in trying to identify a tonic pupil. Okay, sometimes the sector palsy, you can almost even see it just by looking at the pupil where it's a little deformed. Another sign of postganglionic parasympathetic palsy is the supersensitivity. Okay, so this is the reason why you can do a dilute pilocarpine test. So dilute, I mean 0.1%. You have to make it yourself. Now, if I put dilute pilocarpine in your eye, what will happen to your pupil? Nothing, right? It's too weak. It's too dilute. But if you have a denervated eye, like a tonic pupil, you can see this big pupil becomes very small. And the normal pupil There's no response. So this is a positive dilute pilocarpine test indicating a tonic pupil. Okay, now we said that there's something special about tonic pupil, and that's the aberrant regeneration, but you have to wait about 8 to 10 weeks to see this. 8 to 10 weeks after the injury, this big pupil, oops, I'm sorry. Come back. Nope, here, sorry. This big pupil, okay, which still doesn't react to light. Now, if you ask the patient to look very closely at the finger, you can see this pupil is very, very small, okay? This is what we call light near dissociation. When you see this, this is a sign of aberrant reinnervation. It tells you that the accommodative fibers grew back. That's great. But they went to the wrong muscle. They went to the sphincter muscle instead of going to the ciliary muscle. Okay? But this tells you already that the injury is old. Now, how can you distinguish this again from pharmacologic mydriasis? We said first thing, just look at the iris. If you see sphincter palsy, it's not pharmacologic mydriasis. Okay? And with pharmacologic mydriasis, basically the pupil doesn't react to anything. It doesn't react to light or near. It doesn't react to dilute pilocarpine, and it doesn't even react to full-strength pilocarpine. This is pharmacologic mydriasis. You might, again, consider going back to look at the iris to make sure it's not sphincter damage. Okay, now we're going to put away the parasympathetic side, and I want you to clear your brain because now this is scenario number 2. You have a patient with anisocoria, and you check the light reflex, and okay, it's good in both eyes, it's normal. But now when you turn off the light, wow, you can really see the anisocoria in darkness. Not so much in light, but in darkness. In this scenario, there are 4 main possibilities. Once again, this could be an iris problem, like we saw iris atrophy or adhesions. Once again, this could be pharmacologic, but we said this is at the end diagnosis. So really what you should be thinking about here is this physiologic anisocoria or is this Horner syndrome? Now you know that Horner syndrome represents a defect in the sympathetic pathway, okay? And in the textbook they tell you always to look for ptosis, anhidrosis, and meiosis. The ptosis is mild. It's not big ptosis, and it's actually absent in 12 to 15% of patients. So it's not always there. The anhidrosis is variable. Most patients don't tell you that they lost sweating. They don't notice. So really in Horner syndrome, the best clinical sign is the anisocoria, and it's not that prominent. So when you're not sure between physiologic and anisocoria and Horner syndrome, we still depend on the pharmacologic test, and the gold standard is the cocaine test. This is topical cocaine, 4% or 10. And you put 2-3 drops in each eye and you wait 45 minutes. Now what happens? Well, cocaine is an indirect stimulant. It inhibits the reuptake of norepinephrine at the synaptic junction. So if you wait 45 minutes, the norepinephrine is collecting and collecting and collecting, and suddenly you have a big sympathetic boost, and the eye becomes white, the pupil becomes big, and the lid is retracted. That's a normal response to cocaine, okay? But if you have a Horner syndrome, meaning the nerve is damaged, you can put as much cocaine as you want in this eye and nothing will happen. There is no norepinephrine. So this patient has a positive cocaine test because the pupil failed to dilate. Now, I've heard time and time again, that's great, you tell me about the cocaine test, but honestly, my hospital doesn't make topical cocaine. So, the good news is that there is an alternative. The alternative is aproclonidine, okay? And aproclonidine, I think everybody has access to the monodose iopidine, yes? This is the alternative test for Horner syndrome. Now, aproclonidine, you need only 1 drop in each eye. Aproclonidine is a weak or dilute alpha-1 adrenergic agonist. If I put aproclonidine in your eye, what happens to your pupil? Not usually much. Okay, it's a weak agonist. But if you have a Horner syndrome, you're denervated, and that little bit of adrenergic action will dilate the pupil. So in a Horner patient, the big pupil after aproclonidine is the bad pupil. This is a Horner pupil. Now be careful. Aproclonidine cannot be used in infants. It is recommended not under 1 year. For me, I even wait until 2 years because for some reason their immature or early brains may absorb and react to that even 1 drop of aproclonidine. And cases of cardiorespiratory depression have been described, so we don't use it. So now what happens if you see a child like this with some anisocoria, and the anisocoria is worse in dim light, you know this might be a Horner syndrome. Okay, well, the rule remains that cocaine is okay for kids for ruling out Horner syndrome. Okay, so cocaine we can use in as early as 3 months. All right, now this is just a reminder that the sympathetic pathway to the eye is a very long 3-neuron tortuous pathway. It goes down the brainstem, comes out the back of the neck, it crosses the top of the lung, it climbs back up the front of the neck, jumps on the carotid, and then comes out to the eye. It's a very long pathway. Many lesions can happen. What I want you to remember is when is Horner syndrome an emergency? Okay, it's emergent when it's acute, let's say less than 2 weeks, and painful. If it's acute and painful, please consider that it is an acute carotid dissection until proven otherwise. Why? Because an acute carotid dissection in the first 1 or 2 weeks, okay, in the fresh period, there's a lot of turbulence. There's a lot of platelet aggregation and emboli can be flowing. And in that case, in this first 1 or 2 weeks, these patients have a high risk of ocular ischemia, like retinal artery occlusion, or brain ischemia, stroke. So we worry very much when a carotid dissection is fresh. If the carotid dissection is already more than 1 month old, the risk of ischemia drops to less than 1%. So you don't have to worry so much. The other relative emergency, of course, is Horner syndrome in a child. Any acquired non-traumatic Horner syndrome in a child, you must get the MRI to rule out neuroblastoma, and really the child should be referred to the pediatrician for a general examination. Okay, this is the last category. We'll go through this in 2 minutes. You have your patient with anisocoria. This is scenario number 3. You check the light reflex, and the light reflex is poor in both eyes. So now you check the near reflex, and the near reflex is poor in both eyes. In this case, it is probably a peripheral autonomic neuropathy. The most common of the peripheral autonomic neuropathies would be diabetes. But there are some acute ones that can attack the pupil quickly, like Miller-Fisher syndrome, Guillain-Barré syndrome. And I put botulism here. It's not really a neuropathy. It's a toxinopathy, but it acts like a neuropathy initially when it gets the pupils, and after that, you get the descending paralysis. Now, let us imagine you check for the light reflex, and there's no light reflex here, but when you check the near reflex, there's a great near reflex in both eyes. This is, we talked about this, light near dissociation, but now it's in both eyes, okay? When you see it in both eyes, okay, this is an emergency. You need to really think that perhaps there's a dorsal midbrain lesion before you consider any other possibility for bilateral light near dissociation. Okay, so that's where I'm going to stop. Okay. And I think we have time either for questions. If you have no questions, then I brought some cases that we can look at together. So I give the microphone to Piero.
Do you want to use the headphone? Grazie Aki. Confesso che mi commuovo sempre a una lezione di Aki, perché il vero maestro si distingue quando rende più facili, non diciamo facili perché è impossibile, più facili cose estremamente difficili. L'esame della pupilla è un esame importantissimo per noi oculisti perché rivela anche patologie estremamente gravi e quindi siamo obbligati a identificare queste cose. La prima domanda che vorrei fare ad Aki è esaminare la pupilla è importante, quindi è importante anche non dilatarla prima di andare a vedere, quindi non andiamo a vedere subito il fondo, ma prima guardiamo la pupilla. Ma è così difficile fare una diagnosi della pupilla nel nostro ambulatorio? Possono tutti gli oculisti, anche non neuro-ophthalmologhi, esaminare la pupilla e capirci qualcosa realmente, in pratica?
So can every ophthalmologist do a complete pupil examination? And the answer is absolutely yes. The training residents who pass through our service do both an afferent and efferent examination immediately. It takes you 30 seconds to do an alternating light test in the darkness. It will take you another 30 seconds to look at the pupils in light and in dark. And if both of those are fine, you don't need to do more. So it's a 1-minute examination.
You just need a lamp. Not OCT, no campo visivo, no, niente.
Exactly. You do need a focal, bright light. So sometimes the residents come with a very weak pen light. This is useless for us. Okay. And you need a bright face lamp if you want to look at the pupils under bright light.
Tutto chiaro? Sono tutti timidi. Anna, volevi chiedere una?
Quando noi siamo chiamati ad una consulenza e non abbiamo, appunto, dobbiamo andare a letto, perché spesso negli ospedali siamo chiamati a una consulenza a letto, avere la possibilità di vedere le pupille è fondamentale, insomma ci indirizza moltissimo, quindi è un esame che possiamo fare facilmente anche a letto del paziente. Questo volevo aggiungere, insomma.
Vuoi fare vedere un caso, clinical case?
Is that okay? Can we look at a case? Okay. So I just need to go out of here, and in the box there is cases. Yep. And if you just open. Okay, so we're going to start with the first case, and if you can. So here we have a child. Okay, we have a healthy child who is complaining of blurry vision. Who's complaining of blurry vision in her right eye for 1 week. And you can see that the pupil is very large. Okay, in dim light, the anisocoria is less because this pupil gets big also, but in the bright light, wow, we can really see the anisocoria. What else do? We check the light reflex. Well, this pupil is not reacting to light. Okay. What else might we do at this time? A couple of options. Somebody said motility, maybe look at the eye movements. Sure, let's look at the eye movements. Okay, here she is looking up. Here she is straight. She's looking to the right, to the left, and down. Is it okay? Yeah, I think it looks good. Okay. And the resident looked and said the iris exam is normal. So now, what could we do next? There are a couple options. What are some options? Well, one thing we could do, yeah, is, we could go back to the iris, okay, because we're thinking this might be a tonic pupil, remember? If the motility is fine and the lids are fine, I don't worry anymore about a third nerve palsy. But I am thinking tonic pupil. Could you start the video? So, do you think she has sector palsy? So this is sometimes difficult to see, but I'm going to propose to you that if you look here, okay, you can even see that fibers are all bunched up compared to here. Yeah, here comes the, you can see it right here. Ooh, this is very nicely constricting, okay, but the area above it up here is not moving. So yes, this is sector palsy. Sometimes difficult to see. So now we're pretty sure this is tonic pupil, okay? At this point, normally I would stop, okay? But we could do a pharmacologic test. What pharmacologic test would we do if we wanted? Which one? Yeah, good. So we do the pilocarpine. Again, you have to make this yourself. I don't know any institute that provides dilute pilocarpine. So you take your 2%, you take normal saline, and you just dilute it all the way down to 0.1%. Okay? And I put 1 drop in each eye, and here she is before pilocarpine, and here she is after dilute pilocarpine. Look how super sensitive that pupil is. So you definitely have your answer. This is a tonic pupil. Now my question is, what do you want to tell her? Does she need an MRI? Does she need blood tests? What do you do for tonic pupil? Yes, exactly. The big answer is nothing. Okay? This is a postganglionic palsy. We're not in the brain. In most cases, even in children, are idiopathic and benign. If you want to do something, some people do blood tests, okay? But I've never found anything. Certainly you don't need neuroimaging when there are no other clinical findings. The good news is that the accommodation spontaneously improves, okay? And the baseline pupil size decreases. Now, there's one extra rule in children. Because they have this acute difference in their near or reading vision, we do prescribe reading glasses for children just to avoid any possibility of amblyopia, and we give them corrective lenses until the near vision comes back. This is only in children that we would do this. Any questions on tonic pupil? Shall we look at one other case quickly? Yep. Oh, okay. Yes, so Dr. Sadun's question is, what about a small tonic pupil? And what happens is, we said that the tonic pupil initially is the big pupil, and it doesn't react to light. And then if you wait 2 months, that big pupil reacts to near, but not light. And then if you keep waiting, if you wait a year, 2 years, that big pupil becomes smaller and smaller and smaller and smaller. Okay? This is what we call a little old 80. And if you see a little old 80, usually, again, the big answer is nothing. You don't need to do anything, except if you have bilateral, or if you have 2 little old 80s, you have to check for syphilis. Okay, one last case quickly. Okay, this is a woman who complained of photophobia, and she states that her eyes used to be more brown, darker. She's surprised that her eyes look so light. She has no ocular history. Wait. She said, well, my eyes were red a few months ago, and now she's referred for anisocoria. So if you look carefully, this right pupil is slightly larger than the left pupil. But there's no light reflex in the right eye and in the left eye. There's no near reflex in the right eye and in the left eye. And the pupils are the same size in light and dark. They're just stuck at this size. Does anybody have any idea what this might be? And the key is here. The eyes have become lighter. Well, the first step is to look at the iris, right? So here we go again. We're going to look at the iris, and I don't have a great picture of it. So what I can describe for you is she has large areas of depigmentation, granularity, but no transillumination defects. She has circulating pigments in the angle, little keratic precipitates, okay? And you can see she's not really reacting well to pilocarpine. This is, I just want to give you the answer, this is called body. Has anyone heard of this? This is a reaction to an antibiotic, okay? And it's often the fluoroquinolones. And in her case, she had taken oral moxifloxacin 2.5 months ago for a sinusitis. And then her eyes got red. And then eventually she noticed that she was photophobic. So I just want to mention again that looking at the iris can help you with the diagnosis. And as another speaker had mentioned, always think about medication side effects. And this is a benign condition. Fortunately, there is a more severe condition in which they develop transillumination and severe iris atrophy. So this is a medication-induced anisocoria and iris atrophy. Okay, so any questions? Then I think I'll stop here, and again, I thank you very much for your attention.